as we move to a standard for the majority of patients that includes chemo combined with pembrolizumab, perhaps other chemo-IO combinations in the future, that merges two lines of therapy previously. That was, we typically did immunotherapy followed by chemo, or for more patients, chemo followed by immunotherapy. And that leads many of us, patients and oncologists, to ask, what can we do after that? So what would you say we should do after a patient has progressed on typically chemo-pembro or even a sequential approach? What are we left with?
Well, I mean, if you start with pembro alone for the greater than 50%, then you have a clear option of doing platinum doublet, and I think that's a really good option. So if you start with IO, you can always go to platinum doublet. If you start with chemo alone, you can always go to IO. We have data in favor of that. You're in trouble if you start with chemo IO, because what you got left after that is what we tried to run away from, which is your docetaxel and your gemcitabine and the weekly Taxol and things like that, clearly in the absence of a clinical trial. I think in our institutions, we try to put people on trials to investigate this IO chemo refractory patient population and come up with something that can be a little bit more meaningful. But for everyday practice, you go back to dosi, you go back to dosi-ram, you go again to the stuff that, as I said, immunotherapy surpassed and was shown to be good. But I don't see a clear winner in all of this. There have been a couple of really interesting phase 1-2 studies, some of them even with randomized trial. Again, there was a very nice abstract presented in Toronto combining epigenetic and an IO in an IO refractory patient population. The results were interesting. We might even have a biomarker in terms of monocytes for that particular regimen, but it's not a phase 3 study. It's not a home run. There's this combination of RAM plus a VEGF inhibitor, pembro plus ramucirumab, that is very interesting, presented by Dr. Erbs at a couple of different meetings. It is going on to a bigger study to see if it has, the clinical efficacy that you need. So we don't have clear winners coming up anytime soon, but there's a lot of studies, again, in terms of phase 1s, 2s, looking at various combinations to see what would be beneficial.
Charu, what's your approach, particularly focusing on the chemo-IO recipients who progress?
I cringe and offer docetaxel and ramucirumab. I feel that that's probably,
There's nothing to cringe, Charu. It's what you have.
I try not let those feelings show.
But what about, do you think that there's anything to the retrospective data? There are some suggestions that following immunotherapy, response rates can be higher to conventional chemotherapy. I've been encouraged, and I got to say, I've used more ramucirumab with docetaxel, sometimes lowering that docetaxel to 60, but I'm using that more and more as patients are progressing but still have a good performance status and are candidates for more. And I've seen better results than I would have expected to see, certainly from docetaxel monotherapy, and maybe even docetaxel ramucirumab before the era of them getting immunotherapy. So I think we need to learn more about this, but it may not be as dire.
I agree, and I've actually had spectacular responses to single-agent chemotherapy where I've had the hospice conversation and the patients have said, no, I still want to do something, and I've given chemotherapy, single-agent, really hoping for nothing, and they're here, a year later doing well after having had the hospice conversation a year ago. So definitely, I think humbling.
But this is also an area that's fertile for further study, and I think one thing that we should maybe close on is we have not seen data to support very positive results for just trying nivo-ipi after someone has been on pembro or switching from one checkpoint inhibitor to another. I haven't even heard of an anecdotal case that has gone well, let alone data. So that's really not a supported approach.
Absolutely, I agree with you.